Yeah, thank you very much for the invitation to speak here and to present the EU perspective. Thanks also for the two excellent presentations before mine. There was one thing that was said, that we actually need to do something, not just talk about the difficulties. On the other hand, you heard about all the difficulties. So if you start doing something for an economist, all the limitations pop up and you see, well, you tried, but you should have looked at all those difficult issues. So I'm not going to present a study where we actually did something, and in the end we found there are still those many limitations. I would like to talk about an EU project, the EU project EuroGentest, where we did an exercise on priority setting of the genetic tests. So, similar slide, there is a huge number of new diseases for which tests can be conducted, and one clinical area where this is highly relevant is clinical genetic services, where the question arises, which tests should actually be funded and be conducted in clinical practice. We know that the number of tests which is actually done does increase, at least so that's one study for Germany in earlier years. It's not so easy to really do health services research into that topic, but we know there are many new tests. There is an increasing demand of those tests, but there is still the scarcity of resources. In our study we did some exploratory phone and online service, and we found that most geneticists have heard about genetic tests being withheld, delayed, or not provided at full quality due to resource constraints, even if the geneticists felt that they were medically indicated. And actually we found countries like in Italy where criteria were explicitly used for managing waiting lists, so there was some prioritization going on. But those criteria which are used in clinical practice include things like availability of equipment, historical service patterns, or first come first use, which are not the criteria which we would typically come up with if we start reflecting economically or ethically. So prioritization does take place. It's not necessarily guided by ethical and economic reflection, and that was what we looked at and what we tried to explore. So the EuroGentest project in general aimed at the harmonization of genetic testing throughout Europe. And within the development of the second grant proposal of EuroGentest, geneticists felt the need for some tool, and Ulf Christoffersen came up to me and said, Wolf, you're a health economist, can't you create a tool for us to make those decisions about the scarce resources? So, of course, that was an exciting challenge. It needed to incorporate some reasonable criteria, so it needed to incorporate some kind of ethical reflection, but on the other hand there should be some tool, as I was asked as a health economist, so it should be operationalized and should be measured somehow using economic methods. And of course we wanted to do something for decision makers or on behalf of stakeholders, so we needed to incorporate some kind of stakeholder deliberation to this process. We did this together with Genetic Alliance UK as another patient-represented organization, and we did it as part of the activities of the European Society of Human Genetics. We could build on quite good work from the UK. Mark Kröse has done some work on prioritization of genetic tests. That's the work we expanded in our European project. And what needs to be done for such kind of prioritization exercises, you need to have some idea of how should priorities be set. You should have some theoretical framework. You then need to identify criteria which are associated with this idea of how priorities should be set. You need some way of measuring those criteria. Typically it's more than just one criterion, so you need to weight those criteria. And finally, when you apply the framework, then some ranking will pop out of it, and you need to see, does this ranking match with the intuition you had in the beginning when you created your framework. So it's an iterative process. It's not just one thing you do as one circle. I would say we managed in this project to get around this circle once, but it's just the first circle, and there's need for more of them. And of course there's a need to include stakeholders to deliberate about all those different aspects. And that's what I would like to talk about and talk you through this process, how we try to address it during the EuroGentest project. So the first question was how should we prioritize? Typically, we health economists are trained quite consequentialist. We believe that there is some unit of value that needs to be maximized, but still have the impression that doesn't really fit, and it's rather the question, how can we allocate resources according to claims associated with medical need? So that was the idea, to create some framework associated with needs-based claims to genetic test. So where we have the first level, we want to treat people equitably based on claims associated with medical need. And if we want to capture medical need, there is something like severity, like lifetime deviation from normal species functioning, how strongly am I affected. It could also be something like progression, how immediate is the threat to my health? Is it is it a predictive test, or is it in a diagnostic setting where the disease may already be there? So that's the level of health need. But of course, healthcare, the purpose of healthcare is to cure, to alleviate health need. So the question is how this can be captured, for example, by evidence of benefit, which is of course a core criterion. It could also be the expected size of benefit, which is quite difficult to measure in genetic testing. And as I said, there are those 4,000 diseases you could test for. It's just impossible to have a health economic model for all those diseases. So you can just take rough estimates. We took the prior risk of disease as one potential measure. And then of course the claims are directed to funding, to public funding of services, because you could typically also get it funded out of pocket. So the cost of genetic testing services do play some role in those need-based claims to genetic tests. So that's one idea of how you could evaluate genetic test. Of course, you need to operationalize those criteria. If you talk about severity, you need some concept of health. You could take, for example, the well-known EQ5D index. You need some concept of severity, like, for example, the fair innings approach, also quite familiar in the UK, where you have 1 minus health with disease and normal health. So you measure some gap of health between individuals with disease and individuals without disease. You say this urgency, immediacy of health risk plays a role. You need to operationalize this. You could simply take the progression if it's a predictive test, a screening test, or a diagnostic test, which depends on the pathophysiology and the patient characteristic, like age onset, which you would have to define in this certain setting. If you look at medical benefit, you could take the expected sign, whether or not we have evidence of the medical benefit. It could be different types of benefit which could play a role in genetic testing. We took the medical clinical benefit, where we simply distinguish between high or low level of recommendation in the grade scheme. And then finally you have the potential size of benefit. We could took the prior risk of disease, the patient group's prevalence, and for the costs we needed some costing source. So we one European source would be the genetic test by GenDia, which is an agency which provides genetic testing, or which provides information about genetic testing across Europe. So those are information which you could put on clinical utility gene cards, which are something like the gene dossiers in the UK. We try to look for information which we can indeed collect for the different potential uses of the genetic tests. So now we have information, which criteria to use. Now the question is how they should be weighted. We did the standard way, what you're typically doing when you're a health economist. You do a discrete choice experiment. That's a sample choice task where we asked people in the general population. We asked people via the website of the European Society of Human Genetics. So it was those we asked people via the EuroGentest website, and we asked patient representatives with aid of the Genetic Alliance UK whether they should choose between a test with those different criteria with higher or lower levels. The single levels were taken from sample genetic test. There is one instrument which is created by the EuroGentest project, the clinical utility gene cards, which gives some kind of brief information about genetic tests, and we use those brief informations to get an idea of what is the typical prevalence of the diseases, what is the typical severity of the conditions which is tested for. Yes. And if you do a discrete choice experiment, of course, you get your results. what we could find was that the benefit from the tests, proved medical benefit, that was the most important criterion. So if there was a test with a high evidence of benefit, and we know all the difficulties of providing this evidence, this played the most important role. The prior risk of disease, which you could either take as an indicator of health need, but we realized it's rather taken as an indicator of expected benefit. It doesn't make sense to do a test here because there's quite high likelihood that this patient is really affected, and also the cost of the test played a role. We also did some analysis of differences between different stakeholders, and we found that clinicians were particularly interested in those criteria. Patient representatives were less interested in costs and more interested in severity. What can you do? Our idea was to create some kind of tool. Of course, you can simply take those figures. We have the beta coefficients from our study. You could look at some testing case study. For example, you take first-degree relatives of patients with Lynch syndrome. So first-degree relatives, there you have a high risk of having the condition. It's first-degree relative. The severity of the test, you need to calculate the fair innings with Lynch syndrome cancer versus average health. We did a calculation based on an existing model and calculated it to be 0.48, which is compared with the other conditions is tested for medium risk. We had a 40-year-old person, so this person is at risk. If the person was 20, then it would just be a predictive test. At the age of 40, it could actually be that cancer has already developed, so it makes sense to do the test and then to undergo colonoscopy. And you have a clear recommendation in favor of testing, so it's actually the best evidence which is out there for genetic testing, even if the evidence doesn't really meet the thresholds for new pharmaceuticals. And we have the test of the cost of the test. In this case, if you have a known family mutation, would be a rather low-cost test. So you can simply sum this up, and you have a score, and you can create a score between 0 and 100%, and you have a relative priority of a genetic test. So it's a tool based on reasonable framework and quantitative. It is able to rank all the tests. It worked for the clinical utility case studies. And then we did a deliberation study. We did a stakeholder workshop and discussed this with clinicians, with experts, with patient representatives, explained it to the experts, the different concepts, and we realized we are still struggling with all those problems with the two presentations before as mentioned. Generally, the stakeholders like the idea. It does make sense, but still, if you want to do a structured framework, you have to consider all those contextual factors. For example, if you look at progression, of course, someone who might already have the disease is at somewhat higher risk, or it's more immediate than the health need. On the other hand, there are some genetic tests which are only reasonable to conduct at an early situation. So if Lynch syndrome test is only helpful me if I'm at risk. If I'm already a cancer patient, then it's not really that important for me whether I'm Lynch syndrome carrier. It may be relevant for my relevance, but not for myself because I'm in the treatment procedure anyway. For risk, if you look at it closely, frequently medium risk patients are, or the high risk patients are already taken care of quite well compared with medium risk patients, or the intervention need. If you look at the benefit, then you bump in all those problems which the two presentators before me told me, that you have the medical, but you also have the non-medical benefit. You have the benefit for others. You have some time window within this benefit can be obtained. So there are many contextual factors. So, of course, you have a very precise rank using exact health economics method, but that seems a bit too exact and more exact than the decision situation really is. The evidence typically is still too weak really to fit those algorithms very well. So they would favor rather a more qualitative use. So the best use of the framework, according to the stakeholder, was first, the document that came out of this process was points to consider. So if geneticists do reviews of their current practice patterns, they should consider those issues. And it was rather, so now we're first round through the cycle, and it was a valuable exercise. We did something, we came up with something, but we found, so there's still a lot that remains to be done and that remains to be refined. So I'm quite proud about this study because it's a case study, and to my knowledge, it's the only one where European clinical societies said, well, we make a statement on prioritization. Typically, clinical societies would always say we do not want prioritization. So I'm quite proud about this achievement, which is also the former president of the European Society was very much interested in this topic, so that was a good situation. We did one case study where we really went through it. We did something, but we found there are a number of challenges that remain to be resolved, like the evidence of benefit. We need more evidence. We need the question to address the question, what counts as a benefit? We have lots of measurement issues. We have the question, how should we use such kind of algorithm? So that's a lot remains to be done. That's also part of my work, and I would be delighted to discuss this now or later in the break. The methodological questions in the economic evaluation of genomic technologies. I personally believe that one way how to tackle this gap of evidence might be managed entry contracts. So how those could be used, whether and how those could be used for genomic technologies. We have the question on preferences, what role can they play, should they play, which is also a philosophical issue, and the normative question, do we really want to maximize benefit? In Germany, we are a Kantian country, so we typically would not say we want to maximize benefit. So what else could we do? I presented a framework which is more deontological, but still there's more work which is needed. Thank you, and thank you very much also to my collaborators, particularly Francisca Severin, who did all this work I was just presenting.